about modern ART, when and how to start, about prevalence and transmission, how to test, as well as new kids on the block, 3 and 2 drug regimens, long-acting treatment regimens, as well as new as PrEP. So starting off by talking about basics, it's also talking about replication. And we do know that there's how we can block HIV replication. And this is by blocking the entry, blocking the reverse transcription, the integration, or the maturation. And all these enzymes of HIV, we do know where these are encoded in the genome. Here we do see the protease, reverse transcriptase, integrase, and the envelope proteins. This is a viral particle with the enzymes inside and proteins at the surface. And by this, we do have several drugs. We do know for each drug which region we do have to sequence. And for protease, this is a region for protease, sorry, and reverse transcriptase and integrase. And here we do see the Maravioc, the entry inhibitor, and T20. And all these drugs, this is really the great success of HIV treatment, that we are able to have all these drugs at hand. And there are several drugs, and now we have even improved. It's more than having all these different drugs at hand and all these different drug classes, actually 5 drug classes, 2 different drug reverse transcriptase inhibitors. But we are now able to use combination of drugs, and by this now we can treat patients with single tablet regimens. So the adherence, it's an improvement for convenience, but it's also important for physicians because now with one drug per day or one pill per day, the adherence, at least in some patients, is much better than before. And adherence can be easily translated in the occurrence of drug resistance, because adherence is one of the major driving forces for developing HIV drug resistance. So we are still talking about basics, and these basics and talking about drug resistance, for some of these drugs we are using, drug resistance is about yin and yang or black and white. So one mutation is totally sufficient to block or to provide HIV with 100% drug resistance. So all these drugs are ineffective if we are detecting one of these mutations. But we do also have other drugs at hand. And for these drugs, it isn't about black or white. It is a stepwise process. So we do have the virus, and the virus is getting more and more arms, and by these weapons, and to defend against the immune system and against the drugs. And these drugs are some of the NRTIs, but especially protease inhibitors and integrase inhibitors are these drugs with these complex resistance profiles. And for these resistance profiles, we do, for detecting drug resistance, there are several mutations needed. So you do see some of these mutations for protease inhibitors like darunavir. For dolutegravir, you do see these kind of several mutations are needed before drug resistance is detected. But you also see these green mutations, and this is a resensitizing effect. So some mutations are not aren't conferring drug resistance, they do resensitize the virus. And if you do detect one of these green mutations, despite the detection of all these red mutations, the virus might be susceptible for treatment again. So these complex resistance profiles are of some of these drugs. And if we do look at the drugs we are using, which are now in modern or in actually used drug resistance in drug regimens, these are the black and white drugs we are using with where one mutation is needed to confer drug resistance. We do see tenofovir, and on the other hand, these are dolutegravir, bictegravir, and darunavir, which are the drugs with the complex resistance profiles we are still using in modern antiretroviral treatment regimens. So, but it's really important. We are now more and more relying on integrase inhibitors, and we are really happy having these new drug classes at hand. But for this, we do have to realize that raltegravir and evitagravir do have this black and white resistance profile. So one mutation is enough to confer 100% resistance to these drugs. And on the other hand, we are quite happy that we do have integrase inhibitors with complex resistance profile like dolutegravir and bictegravir, where more than one mutation is needed to confer drug resistance. So this is already what was important as basics, talking about basics, but talking about HIV drug resistance is also about talking about prevalence. And the prevalence of HIV drug resistance, you do see the prevalence of drug resistance to to one class only. And you do see that even in modern times, the drug resistance to NNRTIs is still there. But you do see, on the other hand, that multiple drug class resistant viruses are decreasing. So especially multi-drug resistant viruses aren't seen so often and are now really rare cases in the virology lab. And before it was more often, and some patients we weren't able to provide any information or to provide one treatment regimen that might be beneficial for patients. But this changed in 2007 dramatically with the integrase inhibitors at hand, and also Maraviroc as entry inhibitor was really important to change this game. So the prevalence of multi-drug resistant HIV isolates is decreasing. And this is can be also transferred to this really important publication showing how stating or calculating the likelihood for patients showing up with drug resistance mutations. And you do see for patients starting treatment in 2011 and 2014, the likelihood of developing drug resistance is really low. So what about modern antiretroviral treatment? We do have these drugs we discussed before, but we do have some patients, in some patients we do see failure, in some patients we saw failure several years ago, but and in these patients still there is drug resistance and there are emerging drug resistance mutations. And if we use all these drugs like dolutegravir, it was nicely shown that dolutegravir compared to protease inhibitors but it's important to realize that this protease inhibitors was lopinavir, as you see here. So this comparison showed that dolutegravir as second-line treatment is much more potent than lopinavir as second-line drug resistance. And this is our topic today, is drug resistance. So using dolutegravir in these treatment experienced patients after failure of several previous treatment regimens, this is highly potent, and and suppression can be achieved in most of these patients, but still in some patients we do see drug resistance, and we are still talking about how drug resistance to dolutegravir is really looking like, and how how drug resistance might develop in treatment-naive patients. But this publication from the Downing study, we know that at least 2 patients showed up with drug resistance, and this was in non-B subtype. So it's a rare event, but it's important to stay on guard and to observe and to look for changes in the genome. But because even darunavir or the dolutegravir, there is drug resistance. It's rare, but it's there, and it's possible that drug resistance can emerge. And the dolutegravir, the most potent drug we are using in our days, can be affected by drug resistance. It's quite clear from dolutegravir monotherapy attempts, treatment regimens, and you do see that there is failure without drug resistance, like we have seen for several years for protease inhibitors. So, but especially for monotherapies, we do see failure even to dolutegravir with drug resistance, and there are different resistance profiles. And this is what I mentioned before, that that we are still at the beginning of detecting or understanding dolutegravir drug resistance, because one of these mutations is not really conferring phenotypic drug resistance. So we do see an effect, but if you would only look at these viruses, or at one of these viruses, and especially this virus with one mutation, it's if we would test phenotype, it would be not sufficient to understand or to detect HIV drug resistance in phenotypic assays. So the next topic I want we have to talk about is transmission, drug resistance mutations. In Europe, we do have a surveillance program. We do look for drug resistance mutation regularly in treatment-naive patients, and we do see that there are stable numbers of drug-resistant viruses, and this is also true for specific drugs. And if you do look, and this is Richard Harrigan presented this at the European HIV and Hepatitis workshop in Rome last year, that at his center, the frequency of detecting drug resistance mutations was much higher for treatment-naive patients than for patients with failing regimens. So but if we do look more globally, drug resistance and transmission of drug resistance is increasing. So in some parts of the world, we do see a decline, or it's at least a stable transmission of HIV drug resistance, but in some other parts, or in most other parts actually, we do see an increase in numbers of transmitted drug-resistant viruses. So, but now we talked about the basics, what kind of drugs we are using, that resistance is even possible to these modern drugs or integrase inhibitors, but now how to test HIV drug resistance. And we were used to use the Sanger technique. Now there are several systems available for NGS sequencing and drug resistance testing, and but it's still a matter of debate whether this is improving the or it's has a clinical relevance. And at least this study showed that using NGS for detecting drug resistance is, if you do use a lower cutoff, that it's possible with NGS compared to the Sanger sequencing with 20% cutoff, you do see that the sensitivity is increasing, but the specificity is decreasing. So the diagnostic impact overall, it's not so clear, at least from this study. We have done some similar analysis. So we looked in treatment experienced patients, and we compared NGS data from proviral DNA to historical data. And we do see that at least with a cutoff of 2%, we were able to detect 65% of mutations that were historically reported. So it's the other study looked at in treatment naive patients. And if we do talk about NGS as routine technique, it might be important to realize that for treatment naive patients, it might be depending on the region and the frequency of transmitting HIV drug resistance. But it's also that for treatment experienced patients, it might be really important to have NGS at hand, at least in some cases. And this new technique was also used to look at the dynamics of detected HIV drug resistance mutations in proviral DNA. And here in this publication, they were able to see the decline in the frequency of mutations. And this is 35%. And after 2 years, it was only 5%. And then this mutation wasn't detectable anymore sorry, in proviral DNA. And but at the moment, for sure, we are not sure whether these mutations are really gone or whether these mutations are now undetectable in proviral DNA. At least all these kind of studies we can only do by using NGS technologies. So when and how to start ART, and drug resistance treatment failure is one endpoint of treatment. Then at least in some cases now, you have to change. But talking about the efficiency of antiretroviral therapy, it's also important to talk about short-term and long-term safety, tolerability, convenience, costs. And by this, it's also drug resistance is one aspect, but there are other aspects very important for modern ART. And one of these aspects is that we learned, and this is first acute HIV infection. And acute HIV infections, we do have different phases. One phase is phoebic 1, where we are only able to detect RNA. The phoebic 2 is detecting antigen. Phoebic 3 is detecting antibodies, especially IgM, then IgG and immunoblot positive. And doing these acute, very acute HIV infections, where our test systems for testing HIV are still negative in some part, we do know that the innate immunity during these acute infection is starting early, even before we are able to detect RNA. The CD8 T cell response is starting during phoebic 1. Antibodies are also showing up between phoebic 1 and 2. From phoebic 2 on, we do see a CD4 cell depletion, and the viral reservoir is already is increasing dramatically during phoebic 1 and 2. So the concept from this, if you do want to address or prevent the establishment of the reservoir, we have to treat quite early. And it's so one study was that people were identified or diagnosed with HIV during phoebic 1 and 2. These people were high-risk people showing high-risk behavior and were screened regularly for HIV infection, even though there were preventive measurements at hand, but for at least these patients, it didn't work. But starting antiretroviral treatment during phoebic 1 and 2, you do see that the viral load, the DNA, is decreasing dramatically. So we can affect the viral reservoir by treating very, very early. And this was also shown for patients starting antiretroviral therapy within 14 days after diagnosis. This was not so, and these patients weren't all patients doing acute infection. This is in difference to the patients before. But even for these patients, it was an improvement compared to patients starting antiretroviral therapy within 90 days. So the recommendation for same-day ART is depending, and you do see some of the guidelines now available, and it's quite different in different regions. And now you do see these drugs are recommended. And this is why I actually included this in this talk, because same-day ART would mean that we do start antiretroviral therapy without drug resistance testing. And if you do start antiretroviral therapy without testing for drug resistance, you do need these drugs with complex resistance profiles. For these, you cannot use NNRTIs with this black and white resistance profile, and abacavir, where you do have to test for HLA. So this is also affecting drug resistance. Then there are now it's an intense debate how to use 3 drug regimens versus 2 drug regimens and long-acting drugs. These are studies now addressing the aspect how efficient might be 2 drug regimens, and you do see that all these studies are completed, and they have shown the non-inferior, that they are non-inferior, these 2 drug regimens. you do see several other studies already also accomplished and some other ongoing with even new with this long-acting drugs. And these are really impressive data. This is why I'm decided to show you some of these, that darunavir plus 3TC is non-inferior, and you do see these really impressive numbers, how many patients have viral RNA below 50 copies per ml. And there was no difference for 2 drug regimens and 3 drug regimens for darunavir. This was also true in another study for dolutegravir. And again, it was above 90% of patients we were able to suppress. And by this, it's it's not only about suppression of viral load. We do learn more and more about inflammation marker, because HIV is an inflammatory disease. So inflammation is a problem for HIV. HIV replication is one aspect, but inflammation might be the other. And even for these 2 drug regimens, in several studies, it was shown that there was no difference in inflammation, and that there is that these inflammation markers are quite similar. So the recommendation for 2 drug regimens at the moment, at least, it can be used, but at least at the moment you do need some arguments why 2 drug regimens might be better for this patients. It's like if you cannot use NRTIs, if you are not able to test for HLA-B 7057, and you do see that the viral load might be important for some of these, but for others, dolutegravir and 3TC, the viral load might be below 500,000. So most of our patients would be able to be treated if we do at one point skip this part of the sentence stating that we do need side effects, and that it should not be one NRTI used in these patients. And this was from the virology, looking at this, it's quite surprising, because the partner that was best working with one of these really potent modern drugs was 3TC. And the 3TC was one of the drugs with a black and white drug resistance profile. And but this mutations is also this mutations can resensitize. So if you do have this mutation, tenofovir is more active than without, and this mutation can even reverse the effect of other drug resistance mutations. And this mutation is really impacting the viral fitness, decreasing the viral fitness. So in treatment-naive patients, we do hardly see this mutation, because wild-type virus do replicate much better than these mutant viruses. So for the 2 drug regimens, it was quite surprising to learn that even the pre-existence of this mutation was not correlated with virological failure. In this study, it was shown that in patients with carrying HIV with this drug-resistant mutation, we do see more blips, but we don't see virological failure related to the pre-existence of these mutations. And that might be that even though in some viruses only one drug is active, these viruses do have such low viral fitness that they aren't able to replicate, and that so the combination of 2 drugs and even 3TC is still potent to control HIV. And for this, it's also historical testing archived, and you do see if we do not have historical data for all patients, some patients are showing up in the clinics without any historical resistance testing. And if we do test DNA, we have to consider that in these patients, we are able to detect only in 50% of patients this mutation. So all the others we have to rely on our on the treatment history, and we have to assume or to think how likely it was that treatment failure was related to drug resistance. So long-acting drugs, these are the studies showing that long-acting two drug regimens with long-acting compounds are effective, and you do see this is also in integrase inhibitors, but it's related to dolutegravir, but it's not the same, and drug resistance might be more an issue with this than with dolutegravir. And you do see that even the comparison to dolutegravir 3 drug regimens, it was non-inferior, and it might be a really interesting treatment regimen option we now have. But as mentioned before, cabotegravir is not dolutegravir, so drug resistance has been seen in studies and will be seen. So we have it's and also this we do see drug resistance to NNRTIs. So overall, it's quite effective, but we have to be on guard to look for drug resistance, because at least here we do have some concept, and we do understand drug resistance much better than for dolutegravir. So what about new kids on the block? For treatment experienced patients, it's really important, and we do all have these patients, and we do know of these patients, which some of these patients, it was not about adherence, it was about age, because they were starting antiretroviral treatments at times where we just were happy to have some drugs at hand. And with this historical development in these patients, they were able to get more and more potent drugs. But by starting off with this less potent drugs, we do there was the evolution of drug resistance, and by this, drug resistance variant showed up. So they are there, and now we do have some drugs at hand. And fostemsavir is one of the latest drug now, with this randomized trial for drug-resistant viruses after treatment failure. And we do see that it was really an option for some of these, or that it was really effective. There are novel maturation inhibitors in testing. You do see this presented at CROI 2019, this year at CROI, but it would be maturation inhibitors might be there, capsid inhibitors are under development, but these are all phase 1 studies, so it's quite early, and it will take some while before they are coming to the clinics. We do learn more and more broadly neutralizing antibodies, and that in some phase 1 study, it was quite effective, and it was 12 patients suppressed on ART, were given monoclonal antibodies, and 2 maintained suppression beyond 30 weeks after antiretroviral treatment interruption. So it's I'm not really sure whether we should go for monotherapy, but the combination might be really effective. And if we do, this might be really interesting concept for the future to test and to discuss what's going on in the future and how we will treat patients in 5 or 10 years. So the last aspect we have to talk about is PrEP, pre-exposure prophylaxis. If we do use PrEP, drug resistance is an issue if we aren't testing the patients, or these patients do have already acute infection at the time PrEP is starting. So we do have a population of high-risk patients with high-risk behavior, and by this, in these patients, we really have to be sure that that they don't have acute HIV infection, because starting PrEP during acute HIV infection is the surest way to select for HIV drug resistance viruses. And you do see that there's also the issue is acute infection, but PrEP or drug resistance, PrEP is really effective, and we have learned this in several studies, but adherence is, at least in some patients, an issue. And if adherence is combined, adherence is an issue, PrEP might be the reason for selecting HIV drug resistance, because at least in some patients. So if PrEP is used more and more often, we will see some failures, and at least in some of these failures, we will see drug resistance, and we will only learn in the future whether this might be a real factor contributing to a higher prevalence of drug resistance in our overall population. We are hoping for the best because we are preventing HIV, but we will see, and we have to learn whether this is really preventing or decreasing. It will not cause some problems in terms of drug resistance. And this is another example that failure to PrEP might be related to drug resistance. These are only rare cases at the moment, but these rare cases are also important to be considered. So in the end, we discussed basics, we discussed modern ART and drug resistance, we talked about the prevalence of drug resistance mutations, about transmissions, about new concepts for 3 and 2 drug regimens, long-acting drugs, new kids on the block. I'm sorry, again, I want to apologize for the technical glitch at the beginning. It was, I hope it was at the end, you enjoyed it, and it was worthwhile staying with us for this time. So thank you very much for your attendance, and I'm happy to take any questions you might have. So, hello?
Thank you so much, Doctor, for your excellent presentation. Nowadays we are seeing more beginnings of the treatment with ANSTI drugs. And my question is related to patients with persistent viremia or lower level viremias. What is the clinical attitude that do you recommend with this kind of patients?
These patients are really a challenge in routine clinics. It's really a problem. It's depending on the drug regimen you are using. Low-level viremia, we have learned that low-level viremia is actually a symptom. So low-level viremia might be the first step of treatment failure, but it might also be some kind of shedding from the reservoir without related to replication. So I would be really, it's like, and if then you have to discuss with the patient to change a treatment regimen, and changing a treatment regimen is also always a risk factor for failure, because if you do change something doing with the treatment regimen, it's a risk for the future, for the next treatment regimen. So you have to discuss really carefully whether you are believing that this is the first step of failure. You have to talk to the patients about adherence, because in some patients, we have learned, at least in the clinics, that it's about adherence. You can improve low-level viremia by talking to the patients and addressing adherence, but only in some. If you're using new integrase inhibitors like bictegravir or dolutegravir, you might have more time talking to the patients. If you are using valtegravir, I wouldn't stay with low-level viremia. I would switch immediately. So it's depending on the drugs you are using. And we are now quite happy that at the moment at least, we do think that we can talk to these patients, and it's not about changing immediately everything. So our drugs are so potent. Before we were used to switch immediately after detecting viral loads. So this is not true anymore. But so low-level viremia is really an issue, and we have seen that at least in 30% of patients with low-level viremia overall, we were able to detect new drug-resistant mutations. So in the future, we have still to look for factors addressing people, or to classify patients in low-level viremia in terms of failure and low-level viremia in terms of shedding. We are still at the beginning there. So I'm sorry, we don't have a clear answer so far. It's really about patients, and we have to consider this quite carefully. But this might be an aspect for the next webinars. We will talk what we are learning while we are treating patients.
Yeah, because when we start with a low barrier integrase inhibitor like elbitregravir or raltegravir, maybe there is an opportunity to rescue this patient with bictegravir or dolutegravir, but there is not enough evidence to support this, and that's why my question.
Yeah, for sure. And it would be a shame, because if we do select for integrase inhibitor resistance with these low resistance barrier drugs, we might even lose dolutegravir or bictegravir in the long run. So we have really to be careful using these drugs at the beginning, and for this it's really important talking about low-level viremia, because if these patients would lose the opportunity of active dolutegravir or bictegravir for the future, this is more than an issue. It's really it might affect the life expectancy of these patients, because these are the drugs we will see and which will be our backbone for all future treatment regimens.
I have another question, doctor. Yeah. With multi-experienced patients in our country, we use the TRIO scheme. The TRIO, this kind of scheme is supported by the ANRS trial, when you can use raltegravir plus etravirine plus darunavir. And there are some evidence to support this. And can you imagine in the future these kind of schemes are interchangeable? For example, with dolutegravir or ribavirin, doravirine, etc.?
I think we are now. It's about combination, and we have to explore all these possibilities we do have now. And I think at least all for the two drug regimens, there were some failures and some studies showing that it was not beneficial for the patients. So these combinations we have to consider carefully, but it's possible and it's important because we will, with all these patients, we do treat for lifespan. We will treat these patients for 40, 50 years. And drug resistance overall is some kind of it's a risk calculated over time, and the longer you treat, the higher the likelihood of failure. So, and by this it might be related even to drug resistance. We are now having these new potent drug regimens at hand, but we are still getting the experience how this will be end up after 20, 30 years of treatment. It might be an issue after this time. And so in Germany, we are using even dolutegravir and darunavir in combination for treatment experienced patients, combining these highly potent dual drugs. And for some patients, this was really a very good opportunity. And the only one, actually, these patients, some of these treatment experienced patients do have. And this is a study in Germany at the moment ongoing, but the data we do have are quite impressive at the beginning. And it's this concept. So, and this is really an interesting concept to combine our most potent drugs at the moment for these patients. And but we have to be sure that this backbone is still active in these patients. We do need this second, third, or fourth line treatment.
Thank you. Doctora Paulina?
Thank you. I have a question.
Yeah.
What is your opinion about the strategy of treatment simplification for get better adherence for treatment and decrease resistance?
I think it's a really good concept, and I'm always like the concept that you use a really potent established treatment regimen to suppress viral replication, and then simplification is really an issue. If you do think that we are treating these patients for 20, 30, 40 years, there's room for improvement than suppression. To treat patients, it's about suppression of viral replication, but now in the long run, it's also about toxicity. It's about treating patients for 20, 30 years. So it's really important to look for improvement. On the other hand, these patients, we know that suppressed patients do have life expectancy similar to non-infected patients. So these patients might lose the most if we do change anything and using or prevent or in the end ending up with treatment failure. So yes, I do think it's important, and it's really we are improving treatment. We are talking about side effects and everything, but we are doing this in patients which might lose the most if we do any wrong by changing anything. So switching or simplification is important, and it's really important concept, but for some patients it's the highest risk because they are really they are using well-established treatment regimens and with side effects and long-term outcomes that are excellent. So to improve excellent, it's a high barrier to go on. And this we have to keep in mind if we do aim at this. So yes, for sure we have to do this. and we will do this, but we have really to realize that we have to do it carefully and to consider what we are doing, because all these patients, we now are able to treat HIV, and this is the first time in history that we are able to treat most of our patients. And by this, every time we are looking for cure and everything, we are talking about patients which are HIV infected, and these patients aren't anymore patients with a death sentence. They are HIV infected. But everything we are doing in patients which do have life expectancy similar to non-HIV infected patients. So we do more harm. It's a risk of doing more harm than doing good by improving this. So yes, we will learn about this more in the future.
Thank you.
Dr. Mata.
Hi, Dr. James.
Yeah,
thank you for your excellent presentation. I have a couple of questions.
Yeah, for
the
sure.
first one is when we have a biological failure to Trumeg or Biktarvy, we usually don't see resistant mutations. What do you think it happened? Because when we talk about PIs, we can argue about the erratic pharmacokinetics or the GAG mutations, but what is happening with Trumeg or Biktarvy when we have a biological failure, and we can see in the resistant testing resistant mutations?
Yes, I think this is really hard to get a grip on for failure without drug resistance. It's drug resistance, or the detection of drug resistance. We do have to talk about compartments. The CSF might be a compartment responsible, and but there's also the lymph node. And we have learned in recent years, and this is one of the new concepts, that even that the drugs are different in penetrating different tissues. And even this might be that several drugs aren't reaching every tissue in the same concentration. So at one point, it might be that wild type might be able to replicate just because of the concentration. And if we do have this high genetic barrier resistance drugs, it might be that we are quite lucky that the concentration is too low to select for drug resistance. So, but it's yes, we do see this, and this is why we have just to change our definition of failure. And it's drug resistance is in the end. I think failure is starting by detecting replication or viral load. And we are doing this so early that drug resistance and drug resistance mutations, I believe as virologists that we would see drug resistance in some patients and in much more patients if we would continue like we are doing at the first time of detecting HIV RNA. If these patients are staying on the same treatment regimen, we would see drug resistance after 1-2 years. With all these potent drugs at hand, it's a question of time. And in some patients, it's taking more time. And by this, I'm just thinking that our concept of failure, drug resistance, is explaining failure, but it's only one step of this failure. So by detecting and really looking carefully at patients and looking for viral loads quite early and saying, okay, if we do detect viral loads above 50 copies, we are just asking the patients to come back and to confirm this finding. We are quite early at the time of failure. So drug resistance might be in the end, and we have to really realize that in some patients we are too late. There was something went wrong by detecting drug resistance. So we should do to prevent detecting drug resistance. And I think these failure adherence is an issue, concentration in specific tissues. I think even for some patients, it might be a compartment problems, but it might be a problem in different patients. Adherence is always a problem for everyone taking drugs for lifespan. It's at some point in doing life, you have problems to take a drug regularly over 20, 30 years. So it's a mixture, but it's now with these new drugs, bictegravir and all these drugs, we do have, it's possible to, that several factors have to be combined to see treatment failure and to see drug resistance. And it's before it was just one aspect was enough, one failure, one adherence problem was enough to select for drug resistance, and this is not true anymore. So in our days, there's more forgiveness, but in the end, it's about risk and likelihood, and it might be even one phase or one issue of treatment of adherence problems might be enough to select, but it isn't seen so often anymore. And I think drug resistance, and it's the same way talking about low-level viremia, we have to learn and to see, to define failure from shedding or from virus. And we have learned this year at CROI from the clonal expansion of viruses that aren't replicating at all. So we are detecting DNA and probably some RNA, but this is not relating to failure or replication or selecting of drug resistance. So it's really important and interesting to learn more about this, but it's not about black and white. And at the moment, our concepts are still at the beginning for this. So I hope I could answer at least some parts of your question.
Yes, sure. And my second question is about for some integrase inhibitors now are like an alternative regimens. For example, in some guidelines, raltegravir or elvitegravir, compared with dolutegravir or bictegravir for some situation. Do you think that the mutations that develop raltegravir or elvitegravir during a biological failure could increase transmittant resistance in a population?
We are looking for integrase, for baseline integrase resistance, and we haven't seen so many drug resistance. There are only few reports about transmitted integrase inhibitor drug resistance, and we're starting off integrase inhibitors by using raltegravir quite for a while. So doing this all these years, there was no increase of integrase inhibitor resistance. It might be only related to the backbone, so probably we were only lucky. But so at the moment we are at least hopeful that for integrase inhibitors and our modern antiretroviral treatment regimens, it's not the same as it was for all the other drugs. We are now seeing 5–10% of transmitted drug resistant mutations. So, but I'm not sure whether this might hold true for in 5 or 10 years. Because, as I said before, it's about time, and drug resistance is also the aspect time we have to consider. And for integrase inhibitors, it might take longer. It's not happening at all, but it takes longer. So we have to have some kind of surveillance program to learn and to see immediately if there's something going on. Because if we would have 5–10% baseline drug resistance, we would lose our highly potent regimens we are all now relying on. And we are relying more and more on the highly potent integrase inhibitors. But all these dolutegravir, bictegravir can be affected by pre-selected integrase inhibitor resistance mutations. So failure to these drugs might affect the outcome of second or third line treatment regimens. And if this is true even for transmitted, it might, at the moment, it's like a worst case scenario, because we are really relying on this. We are talking about same day art starting at the same day of diagnosis without drug resistance testing. This would be totally unreasonable if we would at one point consider that 5 to 10% might have integrase inhibitors resistance at baseline. So this concept is really depending on the very low integrase inhibitors resistance we do have at the moment. And we have to make sure, and we have to look for this, whether it's also true in the future and whether it's not changing. It might change. At the moment, we are at least lucky, and we are happy with this because our concepts are really relying on this. But we have to be on guard.
Thank you.
I have another question. In my hospital, there are some young patients with HIV by vertical transmission with history of a lot of drugs. One of them have 25 years old. I found interesting the use of ibalizumab in these patients. But outside of ibalizumab, what are the strategies in these patients that I can use?
Yes, it's. I think for these, do you have any drug resistance informations? Do you have any treatment? Is there any? Do you have any testing also for, or do you have only the history of treatment?
Sometimes we only have the history of treatments. Sometimes we don't have the all testing.
I think for these new drugs, I would go for these new drugs. You might skip this. We have seen for the 184 that even the pre-selection of drug resistance is not affecting these new drug regimens. So I think you can treat these patients. Probably I wouldn't go for these low genetic, for these low resistance barrier drugs. But I think, are these patients are now with do they have antiretroviral therapy at the moment?
Can you repeat the question,
do you, are these patients, they are treated at the moment, or they have only the history of during pregnancy, or it's I'm not sure. I would go for these. It might be a concept to go for dolutegravir and darunavir, the combination. If you do have this drug resistance, I'm sorry, but probably I might get the question wrong, but
sometimes they are treated in the moment, or sometimes they don't have adherence for the treatment, so they don't have.
I think for children and vertical transmission, it's really hard because they were treated at the beginning with drugs that aren't so potent. It's about these drugs which you can use in children. And so in all these patients, you do have drug resistance. So it's even without testing, you can assume that there is some kind of drug resistance there. And by this, I think the most potent combination you might have at the moment is darunavir and dolutegravir. It's on the other hand, if darunavir even in the combination, dolutegravir in the combination as 3 drug regimen, it's also highly potent. So I would not go for all of these patients with darunavir and dolutegravir, especially for convenience. And it's really, for these patients, it's convenience might be even more important than for patients later in life infected. And Yes, but it's really hard. I would rather like to discuss this case by case, because it's there is, as we now learn, it's we have to individualize, and we have to look for the best treatment option for each patient, especially in these patients with these specific histories. And this is clearly, we cannot say for these patients, at least it's for sure not true that one size fits it all. So we have to be sure, and we have to look carefully at each of these patients and what might be best. So I cannot, it's really complicated to have some of these. It might be no problem at all. You might be quite happy with these modern drug regimens, but it's each drug, if even it might be effective, it has to be taken, the adherence has to be good, and all this combination might be as important for treatment success as drug resistance issues. So drug resistance is one issue, but I think at least in your case, there are several other issues which are at least similar important for treatment, to achieve treatment success and suppression of viral replication.
Thank you.
Okay, our last question for tonight is by Dr. Hector Cid. He asked that in patients that have or developed the 148H mutation, how much is compromised the activity for bictegravir, and which one is the recommendation for rescue this kind of patients?
It's we have phenotypes at hand, and these phenotypes show that phenotypic drug resistance is lower, or is there, but we are not, it's clearly not fully resistant virus. So it's yes, it's really hard, and it might be that at least for dolutegravir we do have the experience by increasing the concentration. It's recommended in using higher concentrations of dolutegravir for drug-resistant viruses, or if we do have the knowledge about drug resistance. And I think for bictegravir, I'm not quite sure whether it isn't working in these patients. We have to learn this probably in the future. I think we might, I really like the concept for dolutegravir to increase the dosing, and by increasing the dosing, even be able to inhibit replication. And so by this, I think this might be a concept even for drug resistant or viruses carrying drug resistance mutations in integrase. But for bictegravir, we are now translating phenotypic results in clinics, and by this we will see whether these very promising data can be really translated into clinics.
Yes.
But we can be at least hopeful.
Okay, thank you, Doctor.
Yeah.
And on behalf of the CIDV team, I want to thank you for your excellent talk. And that's all.
Yes, thank you for having me. And again, sorry for the technical glitch at the beginning. And it was really a pleasure talking with you. And I really like the discussion most. It's really impressive, and I'm impressed every time what's technical we can now achieve, that these webinars are possible between Mexico and Germany. And so, good evening to all of you, and looking for seeing you again in the future. So bye-bye.
Bye-bye, Doctor.
Thank you.
Thank you.
Thank you, Dr. Jen. See you in CIDV 3.0,
Yeah.
3.0.
Yeah, exactly. In August. Okay, see you.
In
Bye.
August. Bye.